Hello and welcome to Race and Health Matters, a podcast produced by the NHS Race and Health Observatory. I'm your host, Dr. Guddi Singh. In this episode, we talk about closing the ethnicity gap in bullying, harassment and abuse claims, why these gaps persist, and how organisational culture, power dynamics and workplace relationships shape both experiences and outcomes. Let's get to it. Thank you for joining us for this episode of Race and Health Matters. In this episode, we're going to look at this question of the moral heart of the NHS, really. This is why are ethnic minority staff more likely to experience bullying, harassment and abuse at work? And how we can maybe come towards thinking about how those concerns can be resolved. I'm really, really happy that you've all come to join me today. We've got Dr. Justin Aunger, who's a researcher in patient safety and unprofessional behaviours in healthcare. And we've got Dr. Ashok Patnaik, whose sociological work explores how ethnic minority doctors experience the medical workplace and career progression. And we have Felicia Kwaku OBE, who is the Associate Director of Nursing at King's College Hospital and a long-standing national leader on race and equity and staff experience in the NHS. So an incredible group of you to be talking about this issue. And I want to start with a question that actually is to each of you, and it is about how we can name this problem properly. When we say that ethnic minority staff are more likely to experience bullying, harassment and abuse, what exactly are we talking about? And what is it that institutions are failing to understand about this issue?
Happy to go first because I've recently been looking at some of the statistics around this. So my understanding is that, and this is based on the results from the NHS staff survey. So we have almost a decade's worth of data from the NHS staff survey, which show that in terms of the questions in the survey around bullying, harassment and abuse from other members of staff, that is managers and colleagues, ethnic minority staff consistently report, are more likely to report that they've experienced more bullying, harassment and abuse from other colleagues. So let me put some numbers on that. According to the latest 2025 NHS staff survey results, 23.4% of ethnic minority staff reported that they had experienced an incident related to bullying, harassment and abuse from other members of staff in the last year.
So it's like almost a quarter, isn't it?
Yeah, almost a quarter, in comparison with 19.6% of white British counterparts. And you see that steady 4% difference almost every year from the time the NHS staff survey has been carried out. So over the last 10 years, so it's been a persistent problem where you see that almost 4%. I mean, the difference has been declining over the years, but it's been declining very, very gradually, and it's sort of hovered around that 4% mark. So I mean, that's what I mean by the fact that NHS ethnic minority staff tend to experience more bullying, harassment, and abuse from other members of staff.
Lovely. So you've given us the stats there.
And I think internationally as well, this issue is starting to see more prominence. NHS Race and Health Observatory obviously is doing a very good job of shining the light on this issue. But historically, it's been in there in the statistics, and I think NHS managers and leaders, some of them have been aware of the issue. Ethnic minority staff obviously have been very aware of the issue. But over time, it's becoming more part of the conversation. And I think there's starting to be more pressure on NHS organizations to start addressing the issue effectively. But right now, we don't know exactly how to address it most effectively.
How about for you, Felicia?
So for me, this issue around discrimination and racial discrimination that we're talking about is not new. We know that we've had opinions and devaluing people because of their colour for many, many centuries. And that intolerance seeps into the judiciary, the police, the legislative systems, and it seeps into health. And considering that we encourage people to come to this country, considering that until recently we were formally recruiting people to this country, so there is acknowledgement of diversity, and there's acknowledgement that we need people here to help and look after and care for our health systems. But on the other hand, there is an intolerance to that difference of people coming here, and the reasons, some of those reasons are because colour and race is not seen as of value. within populations. And the darker you are, the worse your treatment in the racial hierarchy pyramid. So it's this intolerance of difference that's the problem, really. And the intolerance is seen as something not to be liked, not to be tolerated. And that seeps into people's behaviour. It seeps into care, seeps into health. And we should be concerned that we are treating people in a unfair way. And what the impact of that is on the people that they care for. We should be worried about that. And we should be doing everything that we can to reduce those kind of behaviours, those intolerant bullying and harassment behaviours.
Yeah, thank you all of you. And thank you for historicising this, which is that it's not a current workforce issue. This is not just something that's happening right now. It is obviously built on centuries worth of oppression. And we can say the word, right? Empire, and how those hierarchies are seen in our society. Justin, I want us to think about, from a patient safety and organisational culture perspective, actually, how we should understand bullying, harassment and abuse between staff. Because I think sometimes there's a tendency to think of it as isolated incidents, but really it's a pattern, isn't it?
Yeah, and there's a lot of incentives within organizations to kind of frame it as an issue of, oh, we have some bad apples who work in our organization. But I think bullying, harassment, and abuse needs to be understood within the structures and systems that exist, similar to the ones that Felicia was talking about. Obviously, we work in a society and we live in a society that has issues with racism, and these arguably are becoming worse. And the same goes for organizations. There's a lot of incentives for organizations to try to protect their own reputation over addressing and calling out specific instances of bullying, harassment, and abuse, especially when they have a basis in race. And so what we really need to do is try to acknowledge that the organizational systems and structures need to change in order to make sure that the drivers of bullying, harassment, and abuse, things like frustration in the workplace, things like understaffing, things like people getting away with poor behavior for a very long time, these start to be addressed and actually dealt with.
Yeah, and that's brilliant that you're talking about those drivers there. But I wondered whether you could also just, for the listener, just give us a picture of what kinds of behaviors are we talking about here? When you say that we're talking about bullying, right, or harassment, what is getting normalized in our systems right now, long before they're actually even named as unprofessional?
Yeah, so there's a great deal of research on this around the world, a lot coming out of Australia, but also in the UK, and how people conceptualize bullying, harassment, and abuse. There's a lot of issues with that. Some people think bullying is like a one-off event. Other people think bullying has to be a pattern. But what we do know is that even mild rudeness is extremely common in the NHS. And if you ask staff, how much do you experience rudeness from your colleagues, people report that at like a 90% plus rate over the past year, for example.
That's an astounding statistic.
Yeah, and so this rudeness, it can have significant effects on how people work efficiently together. It can affect patient safety. It obviously affects staff well-being significantly. And even these types of so-called mild issues actually have an insidious impact when you look at the entire health system.
I mean, 90% sounds like a miserable workplace to me. So
yeah, and obviously it's not everyone is doing it, but there's enough people doing it that and everyone has a bad day sometimes.
Sure,
it has an overall significant impact.
So Ashok, I wondered whether you could talk to your work and about what it suggests about how ethnic minority staff encounter the workplace differently. Not only in those overt moments where it's obvious that somebody is trying to harass you, but actually just in the everyday texture of professional life. Can you give us a sense of what it's like to occupy that space as another?
Thank you, Guddi. Yeah. So I guess as an ethnic minority member of staff working in the NHS, your day-to-day lived experience of bullying, harassment and abuse might consist of microaggressions, for example, simple things like people not taking the trouble of getting your name right or distorting your name. So, and that can be perceived as a slight or an insult. But it can also consist of so many different forms. Justin was talking about some of the ways in which bullying, harassment and abuse manifest. So things like being spoken to in a disrespectful, insulting manner. There's, this taps into racist prejudices and stereotypes around ethnic minority people having less intelligence, being incompetent and lazy, and therefore, they are over monitored. They tend to experience constant surveillance, and as a result, they also tend to face harsher performance management regimes, and they feel like there's a much smaller room for error for them. They can be, given that healthcare is a small world, there can be, slander, innuendo, gossip about them, which can, damage their reputation and their career progression opportunities. Ethnic minority people also, so a higher proportion of ethnic minorities might be Muslim as compared to, the white British population. They might also encounter both racism as well as Islamophobia. So, comments about their appearance or, the lack of sensitivity to their needs and lack of provision, for example, for halal food or for prayer spaces. You could have overt abuse directed, which is intended to demean or to hurt somebody or to make threats. So there are lots of ways in which ethnic minority staff. People could intentionally or unintentionally derail your career. By denying your career progression or developmental opportunities. So this problem manifests in so many different ways for ethnic minority staff.
Yeah, that's brilliant. And you've really painted a whole spectrum there, haven't you? From those kinds of interpersonal, to your face, or even behind your back comments that might be passed, but actually all the way up to almost the kind of Foucauldian bureaucratic control, right? Over your jobs, over your surveillance you mentioned. Yeah. It's going to obviously enter one's psychology, and it's going to have its effects. And I'm wondering, Felicia,
can
from
I
your...
just quickly add one other important thing?
Yeah.
Ethnic minorities, even though they are fairly well represented within the NHS, they often struggle, especially in white-dominated workplaces. They're often minorities, and they struggle to experience a sense of social inclusion.
Yes.
So deliberately excluding, and ignoring someone, that can again be an important part of the ethnic minority experience.
No, that's a really, really good point. And actually, I was wondering, from your perspective, Felicia, because you've got the clinical and leadership perspective, what does this problem look like on the ground when people are actually trying to do their jobs well and care well, but they might be coming up against some of these barriers?
So what my colleague has just described happens every single day across the healthcare landscape and healthcare provision. And I mentioned earlier that we should be concerned because, we have evidence that shows that, traumatized staff cannot give and cannot provide really, really good care. So what it looks like is that we often say that the NHS is very diverse, but it's not equitable. So for tangibly speaking, it means that people's career ladder is stunted. I met somebody just yesterday in a different hospital, and I'd known her name, and I said, "How long have you been a band?" I said, "What grade are you?" And she said, "Band 7." And I said, "How long have you been a band 7?" 17 years.
Wow.
17 years.
That's not normal, is it?
No. People, it shouldn't be normal.
Right.
But for individuals from ethnic minority backgrounds, that can be normal. So I said, and what is, it's not interesting, but what's harmful is that people that she would have trained with at the same time in the same year, they've all gone on to progress. And she's left in that particular grade.
And those colleagues are white.
So it's about career stunting. It's around not being psychologically safe to do your work. So you go into work with trepidation and nervousness. It is sometimes even standing in the lift with certain patients that may not look like you, but you feel nervous to maybe stand next to them. And I see every week staff being exposed to really bad racist and aggressive language from patients as well. I actually think it's getting worse. And for staff, what staff come into the workplace to do their best, and you have to stand there and sometimes tolerate really offensive language from the people that you are caring about. So you have to temper. So we talk about coming into work with your authentic self. Sometimes you cannot be authentic at work because you have to tolerate a level of abuse, from your colleagues and from sometimes the patients as well. So how do you lose yourself? How do you function well when you have to lose a bit of yourself and give much more of yourself than you normally would do because you're trying to defend yourself? I think the other ways that bullying and harassment manifests itself in the ability to speak up and speak out. So often we say often organisations will have really good solid whistleblowing policies, but to actually speak up and speak out costs you. Yeah. And if you are being bullied and harassed, it's not simply to say you're going to report it because that's the right thing to do. You have to weigh up the cost, the personal and professional cost of speaking up. Do you do that and you risk some managers coming down on you really hard, giving you a bad appraisal, making your life really, really difficult and ostracizing you? Or do you speak up and speak out and know the cost, but you're still going to do it because it absolutely needs to be said? So the other thing around bullying harassment as well is that if you're in a constant state of trauma, you make mistakes.
Yes.
Okay. That impact on patient outcomes and their survival. So trauma, as I said, we have lots of walking wounded in the hospitals. And when staff are treated really well, they do discretionary effort. They give more and more and more. They are happier. They look happier. You have less complaints for patients. You have really good atmospheres where people can thrive and flourish. And when you don't have that and people are constantly being bullied and harassed, the performance goes down. The team dynamics are impacted. So small things that you would tolerate, they become much more amplified when you're working in very traumatic situations. And really at the extreme end of that, it can kill you, okay? And it can affect your health and well-being. So that's the extreme of what bullying and harassment, how it manifests in the healthcare workforce.
That's really powerfully put. And I mean, even the language that we're using here, like the walking wounded, the trauma, I mean, it sounds like a war zone, doesn't it? It sounds like the kind of stress that no one should ever have to deal with at a day-to-day, normal job. This is meant to be a caring profession, right? This is meant to be a place where people experience care. In my own research, I've come across this exact sense. It's moral distress, isn't it? And it really is distress when you've got the values of an organisation that says one thing, but then actually behaves in a completely different way, right? And when it comes to their own workers, let alone the patients. I'm interested in this idea of culture because we talk sometimes, like the medical culture, it's almost a way of excusing it. Oh, that's just the culture of medicine, or that's just the culture of the health world, or whatever it is. And how much is that just a language that allows inequality to become ordinary? How much of it is do we just allow things to be because that's just how it is? That's, how do we push against that? How do we start trying to illustrate that this is not normal? This should not be normalized. And I'm curious as to your reflections on how do we kind of change the language around this? Because language is powerful, right?
It's difficult. We need to be honest with ourselves that many of the systems, including healthcare, I'm just going to be frank, they're not really designed for people that look different to flourish. We have to be really honest about that.
Yes.
It does happen, okay, in the right organisation that understands about how we do things around here, and how we do things around here in terms of culture means that it's not just saying that you're committed to diversity and race equality, that you are absolutely doing the do. Okay, so you are doing the actions that speak very loudly to your staff, that you are engaged about equality for all, with all the 9 protected characteristics, that your board demonstrates, okay, that you're committed to race equality because you've got really diverse boards that look like the local community, that look like the staff that you are employing, that understand cultural nuances, yeah? We are not, people of colour, brown and black people, we're not a homogenous group. There is an overall culture, and then there's a culture within different groups and communities. We know that. You've got to understand those different nuances within an organisation as well. And I think there is one thing when we talk about culture, is that for black and brown people, we carry our people. Our white colleagues don't function, they don't flex like that. We do,
right,
okay? Yeah. Something that's innate in us. And we know that there is, evidence that Professor Williams quotes that when, for example, a black person gets treated really badly by the police, it doesn't just affect that person's family, it affects the whole community, okay? That's what we carry. So this issue about culture involves understanding the culture, how we do things around here. The accountability piece is really important, and the bravery and the courageous piece is really, really important, because you have to, I think those leaders that get the culture really right in their organisations is because they're willing to put their heads above the parapet. They're willing to be bold and brave. They demonstrate their impact in terms of credible leadership because they've got the data, the staff will tell them, and the patients will also tell them what it feels like to be cared for in an organisation that's got all that culture absolutely right. Understand all the problems, we understand that, but when the problems come, they can deal with them really well, and the staff feel that, live it and breathe it as well.
I just want to pick up on what you said there, because there's something really interesting in that idea of like these systems are not built for us.
Yeah.
So Patricia Hill Collins has this really powerful way of describing this distinctive knowledge that you kind of pick up as you navigate a system and structures with this that are not built with you in mind. And you end up having to quite a good way of like figuring out these systems, but at a cost, right? It costs you in terms of trying to navigate that, trying to understand the duplicity of language where two things might mean different things. But I loved what you said there about like it doesn't just affect the person who's experiencing the harassment, it reverberates out. And actually, Ashok, I wanted to turn to you and talk about reverberation in a different way, which is that it doesn't just happen and it just stays, it happens in an isolated event and it's that job in that particular hospital or whatever. It occurs throughout the progression of one's career, doesn't it? And I wondered whether you could speak to that. What are some of the recurrent patterns that we see that shape experience over the progress of someone in their career?
Thank you. You're absolutely right, Guddi. These are not isolated incidents because they do send out those ripple effects, and they affect not just the individual, but all the people who are observing what's going on. And in one of his articles, Justin talks about the concept of moral injury, that if you see someone being, from an ethnic minority background being bullied, harassed or abused, and you don't do anything about it, then that affects you as well. You feel that you ought to have done something and you didn't, and you carry that guilt with you. And it sends out a message to people across the organization. It conveys the message that bullying, harassment and abuse is tolerated, it's normalized, it's accepted. And that not only encourages that kind of behavior and makes it more likely to be perpetuated, it also, creates the opposite of an inclusive workplace. And it, I think, reinforces the sense of double standard that a lot of minority ethnic staff experience. Felicia, you've talked about careers being stunted. This kind of experience, the lack of support from managers, from allies, who choose to remain silent. I mean, we heard a lovely quote from Professor Williams yesterday, that all it takes for evil to flourish is for good people to remain silent. So this, lack of support from allies, it can be so demoralizing. And that, it doesn't remain within that one isolated incident. As, you've both mentioned, it affects your confidence. It plays on your mind. It affects your performance. It increases the likelihood of clinical errors, which has impacts on quality of care and patient safety. It impairs teamwork, breaks down communication. So it affects the culture of the whole organization. The whole trust is corroded and damaged as a result of these incidents. If you can imagine a lot of these things happening all over the trust. And what we see from NHS staff survey data is that it's a very widespread and pervasive problem. It happens in 90% of trusts across the country. You can imagine, how much, damage is being caused as a result of this. And, that sense of, my colleagues are not there for me, they don't care, that affects people's career progression in, a lot of indirect and subtle ways.
I mean, again, such powerful statistics there. 90% of trusts where this is happening.
Yeah.
I mean, we can basically guarantee that you're going to go into a trust where something like this is happening, which is kind of disheartening, right? Especially for when I look at younger trainees who are coming up in the system. It just feels really sad. Justin, I wondered whether I could turn to you now, and in your work around unprofessional behaviours, can you maybe help us to explain what is it that organisations are often missing about these behaviours, and why is it that allows these behaviours to be sustained? What is it that us organisations are blind to?
There's a lot of different issues that are driving these behaviors. And I guess a lot of organizations, they don't necessarily have the capacity, the resources to really delve into what are causing these issues. Some are obviously fighting against headwinds from wider society that contribute to racism overall. But with respect to wider unprofessional behaviors like bullying, harassment, and abuse, organizations, they need to understand what's driving these behaviors in those organizations. They need to speak to staff, figure out, what is it that you think is contributing to these issues. There might be things that are solvable, small wins that you can find in some cases, such as people having overlap in their job roles that cause unnecessary conflicts. There might be small things that are causing people to unnecessarily butt heads, as it were. But there's also obviously issues with some people who have a consistent pattern of negative behavior and is never addressed and never listened to sufficiently by leaders because maybe they're, high-performing surgeons or something like that, and they're extremely difficult to replace. But what we see in other countries is that there are interventions that are wider scale. Some are called like professional accountability programs, for example, that make sure that when certain people have a lot of reports about them, that it's dealt with in a efficient and but fair way at the same time. And so I think organizations, while they do currently obviously have a lot of constraints on the amount of initiatives they can put in place to try to address these behaviors, there's nonetheless still a lot more focus that needs to be needed on tackling them.
Sometimes I think organizations can hide behind the difference between what they perceive to be the serious, formal event or harm that's occurred and what we all can talk about as everyday disrespect.
Yeah.
And I wondered whether you could talk about the relationship between those two things.
I mean, I think the extreme behaviors that happen and the extreme cases of bullying, often those do happen with, certain sets of people or cliques in the organizations that have poor behavior going on. I think the wider pervasive rudeness and these types of behaviors, unfortunately, everyone can have a bad day. And if you're trying to deal and do jobs that are extremely difficult in a healthcare context, unfortunately, probably everyone at some point will say something, maybe inadvertently even, that can cause other people offense. So these types of issues, they need to be dealt with and understood in a fair way, in a way that is restorative, in a way that is just, and needs to be understood from organizational perspective that these things can happen. I think programs and initiatives to tackle it need to maintain that fairness and that perception that they're not going to be unfair to me, because that can also affect ethnic minority staff, very significantly, especially when there's cultural barriers or you're working with people internationally and there's just different communication styles. So there needs to be a fair and just process for tackling those types of smaller things. And often, it can just be a conversation. Like the way I heard what you said yesterday, didn't come across in the way that I would prefer it to come across. And those things can often be resolved kind of casually with the help of a manager. But the pervasive patterns of severe behavior, those really do need the kind of organizational leadership to listen and to address those issues in a way that respects staff who are bringing those matters to their attention.
Yeah, it strikes me, again, perhaps from personal experience, that often this is this happens to you twice. So what happens is that not only do you have the initial injury of something being said to you, but then you have to kind of prove that it happens.
Yeah.
So you have this inequality that is about having to basically not just that, oh, something has happened to me, but now I have to make the case that this is happening to me. And people are still going to not believe me, right? And
what racist person is going to actually say that they're racist? So this is the issue, and that's why a lot of employment tribunals don't succeed, because there is a premise that, well, thank gosh we have the legal system, because the legal system says that if you have an intention, if the racial discrimination is the intent, if the intent is shown, that can also be proven. So it's not just relying on a physical verbal act. There's also the intent. And in the Michelle Cox case, that was clearly proven. The intent was there, as well as direct racial discrimination. So it's difficult, like you've just said, it is difficult because of that admission, that knowledge. And I sometimes think about this issue of trying to tackle bullying, harassment and racial discrimination. Some of the difficulties is because the actual person, the perpetrator, in order for them to really understand the damage, it's got to come from deep here. It's a spiritual, moral, their way this person thinks, the way they've been brought up, all their ideology, it stems from inside here. And it can be difficult to challenge that internal bias that sits within somebody's moral or heart, their heart. It can be really difficult, because to actually acknowledge that and say that you are discriminatory, you are racist, or you are, you have this level of hate and intolerance for people, they're not going to admit that to you straight away. And we have many people like that walking around like that.
Well, I would also just say that probably a lot of people are just unconscious of the fact that they hold these beliefs. And I mean, I think a lot of people...
It's a mixture of both.
Well, I'm sure. I know, like let's be honest, lots of people go into the healthcare profession because they're good, right? They want to do good in the world. Yeah. But that doesn't mean that they're perfect, right? And it's exactly what you said, right? How do you challenge someone on something that's going to be quite core to their identity without everything falling apart around?
And that's about leadership then, isn't it, Guddi? It's about the leadership structures within an organisation, which you've just talked about. The leaders set the tone, don't they, within organisations? So if you have a fantastic chief executive, a fantastic board that is very clear about the culture that they set within the organisation, that they will not tolerate certain behaviours, that they will hold people to account for certain behaviours, especially discriminatory behaviours, that that within the department, if the chief exec is ringing up the manager of that department to say, oh, I can see a trend that you've had 10 disciplinaries and 7 of those disciplinaries involve black and minority ethnic staff, that manager is going to step up and say, I've got a problem. I have a system here. The same in COVID. Remember in COVID, the first guidance around staff that had the disproportionate impact on BME staff of COVID, those first lot of risk assessments, they didn't reflect any of that at all. But we knew that there were some really good examples of leadership, chief execs and staff within some of the organisations that picked up on that really quickly, because the leadership structures were on it. They had the data, they were interested, and they had a can-do culture about fixing and addressing those issues.
You bring up a really interesting topic.
Could I just quickly add on this and want to move on? This topic of being able to prove that something has happened, that is so important. And I think in addition to everything Felicia spoke about, I think what exacerbates the problem is that a lot of, we've heard yesterday about how ethnic minority staff tend to be concentrated in the lower rungs of the NHS hierarchy, and the leadership and management cadre within the NHS is disproportionately made up of white staff.
I mean, it's just not reflective, is it?
Yeah, I mean, that creates a problem, because if you have white people, if they are the ones who are deciding whether a form of behaviour, meets the definition, can be classed as bullying, then there's a problem there. Yeah. In addition to that, if you what I've heard from a lot of ethnic minority staff is that often there can be a form of rationalization and often gaslighting from other people who have observed what has happened.
Yes.
Oh, that was just joking. That was just banter. You're taking it too seriously. You're taking it too hard. Things like that. And then there is the problem of the opaqueness of the definitions of bullying, harassment, and abuse. A lot of ethnic minority staff, haven't had, any communication or any training in what types of behavior can be classed or reported as bullying, harassment, and abuse. So when it's happening to you, you don't really realize it. Yeah. And you don't, therefore you're not even, going to the trouble of documenting what has happened to you. And therefore you can't prove it after the fact. I remember interviewing one consultant, an ethnic minority consultant. He talked about the tragic death of Dr. Vash Kumar at University Hospitals Birmingham. She was belittled and bullied, and she tragically took her own life.
Oh my gosh.
And this doctor who worked in the same hospital said, everyone knew what was happening to her, but no one could prove it. Yeah. And therefore, nothing happened to anyone. So that problem of being able to, and another interview talked about how do you meet the threshold? Because accusing someone, a colleague, of bullying, harassment, and abuse is quite a serious thing.
Yes.
And how do you know that, a pattern of behavior meets that threshold? So it's really fraught and complex and thorny problem.
And again, it speaks to that mismatch between what is available to us and the formal routes and what we have available to us on the ground. Because we talk about this almost as if it's just a question of reporting. Yeah. It's like, what mechanism do we have? Is there a policy? Is there a process? And even if there was that, I think what you're saying is that actually if the culture is not right, you're not going to feel psychologically safe enough to actually raise the flag on it. And for all sorts of reasons, right? Yes. And again, the burden of that work falls on the victim, right? Yes. It falls on the very person who is already feeling minoritized in so many ways. In the NHS right now, things are moving in the right direction. There are standards on violence prevention and sexual safety, which are moving in the right direction, slowly. And there is a stronger emphasis there on this idea of cultures trying to take care of employees. But this question is to all of you. What would a genuinely preventive approach to racialized harm look like in this system? Because at the moment, it feels very much like it's a reactive thing. We respond to the case after the fact, as opposed to putting into place a preventive approach to racialized harm within the health system workforce. And I wondered what your answer to that would be. Like, what would that look like?
So I think this is a very important question. And I think probably the main word that comes to mind when I think about how to address this issue is accountability. And at the moment, you have a system, as we talked about here, where the culture is very much shaped by leadership. And at the moment, I think while the data is getting better around, who's experiencing these behaviors, what we really need to see is a move towards leaders perhaps being held to a performance standard when it comes to, for example, the levels of inequality in bullying, harassment, and abuse. And part of the thing we're trying to do in our project that we're working with the Race and Health Observatory on is to work on targets for trusts that we know are achievable based on trust characteristics, so that trusts know what kinds of improvements are possible to make based on other similar trusts in the country. And so that then leaders will have targets to move towards. Ideally, further down the line, leaders in their performance management, whether it's CEOs or chief people officers or these types of things, need to have systems that will make sure that they are keenly aware of this issue and kind of put on the pressure from a top-down perspective to start working on putting in initiatives that are evidence-based that will help to tackle this issue.
Brilliant. Ashok, I think you...
I'll wait for Felicia because I spoke a lot last time.
So, that's okay. It's very...
so thank you for that. We are living and working and existing in very politically volatile times. We've seen some patterns. Remember with Southport, and we had nurses being stoned in the streets.
Again, which is just crazy to think about, isn't it?
And we have just had results of some local elections, and you're talking about prevention. We are going to have to do something quite drastic, I think. And our language is going to really need to change, because we have to kind of balance out what's happening politically as well. It's not just about systems and putting lots of tools are. it's also about how we stand up as people and allies of people, of black and brown people and black and brown patients in these politically volatile times.
Yes.
Yeah.
So that may need to be that we think about what our activism is going to be like within these geopolitical times.
Yes.
It's going to maybe mean that, you know, how do we get into some of those political systems, either as councillors or mayors? It may mean that. It might mean that health care personnel kind of diversify into some of those non-traditional landscapes where they can influence, because it's going to need more than what we traditionally do. It's going to need more bravery, more courage, more political drive, and trying to impact what happens at a policy level as well. We've done a lot of things. We've had a lot of guidance. We've had a lot of data, and it doesn't change.
Yes.
And even when it does change, it's really, really small. So we're going to have to think really careful about what that approach is going to be.
So I would say the two most important things are firstly feedback and I go back to the word that Justin used, which is accountability. So what I mean by feedback is a lot of ethnic minority staff who've experienced bullying, harassment and abuse say that when they report an issue, they don't get any feedback from their managers about what has actually happened. And this breeds a sense of futility and cynicism, like, what's the point?
Yeah, so they don't close the loop on it.
Exactly right. And the second thing is deterrence, which means that when an incident is reported, the leadership takes it seriously, doesn't dismiss it, and actually does something to show that that kind of behavior is not accepted or tolerated. You talked earlier about, why such behaviors are normalized, and a major reason is that because nothing happens to the perpetrators. In the worst case, they might be moved to a different department where they continue to exhibit the same behaviors towards other staff, or, in most cases, nothing happens. So real action from the leadership and the management, that is really important in sending out a message to staff that these kinds of behaviors, and that might mean difficult choices for leaders and managers. Justin talked about, if you're a high-performing surgeon, if you're a good clinician, people are more willing to cut you slack if you're not demonstrating the right values and the right behaviors, which means that those values and those behavioral norms have to be accorded at least the same degree of importance as how good you are clinically. So that is a tricky challenge for leaders and managers.
Yes.
A few other things. Felicia, you talked about how the NHS has diversity but not inclusivity, and that's again something that's come out from my interview. Staff talk about
equity.
Absolutely. How if you're a white manager and you're managing a team of, let's say, 25 people, of which 2 people are ethnic minorities, how do you ensure that the 2 people also get feel how do you treat them equitably so that they also feel included in part of the team, so that they're not feeling excluded or discriminated against? So training for managers in terms of building inclusive workplaces, I think that's really important.
Training has been shown not to make as a significant impact as it should do.
Oh, say more. Tell me more.
So, and we heard some of that yesterday, but and we heard, so on Monday we attend. I don't want to cut in too much to Ashok saying, but we had a chief nursing officer and chief midwifery officers Black Minority Ethnic Strategic Advisory Group conference. And we had Roger Klein there, who's well known in the circles, and when unconscious bias training came, everybody grabbed onto that, landed onto that. But the evidence shows that it didn't really make an impact in terms of changing people's attitudes, because you have to formally do that, don't you? You have to be conscious about changing your mind, your heart. And he also talked about training. And I don't have the stats to hand, but also race equality training and all the other trainings hasn't shown to be as successful in terms of changing culture as it should do. The things, for example, that change culture is accountability, is deterrence, but also things like having strong human resource policies and protocols that actually make a difference and actually work. Leadership, all of those kind of things are the things that if you like, turn the tide in terms of changing attitudes and protecting staff. And I think there is something about not naming, shaming, but holding the light up to some really difficult cases, and even organisations are not pretty good at that. When organisations have really difficult cases of employment tribunals, what they should be doing is discussing that amongst their employees, what the learning has been, what they're not going to do, if they face those things again. So I just wanted to just inject that as Ashok is responding.
Thank you, Felicia.
Yeah.
You're absolutely right. I
Yeah.
completely agree. I think the training, whatever training is put in place, has to be meaningful.
Yeah.
It can't be the kind of mechanistic tick box training.
We've all sat through that, haven't
Yeah,
we?
so much of our mandatory training is,
Yeah.
just quickly,
Yes, yes,
answer all
yes,
the quizzes
yes.
and
Yes.
complete the training. It has to be much
Yeah.
better. If you look at well-managed organizations in the private sector, they invest a lot of effort and resources into proper training that actually do result in meaningful behavioral change. So I think that, is a, much, more robust form of training is needed.
You have such incredible insights, all of you. I feel like what I'm hearing from all of you, actually, in different ways, is just saying that it is not enough to talk the talk. It is about walking the walk, but that requires a kind of moral seriousness more than anything else, right? Because as you said, it comes from within.
Yeah.
It's from within your heart, but it's got to be right from the ground. Interpersonal allyship has to be like a really serious thing, because you can't just have the policy if you're not going to be supported by your colleagues. But it's got to be very well thought out, right? An NHS trust has to think about every single aspect of what creates a culture, such that actually there are the conditions in which someone can feel safe, that they're being supported, and that there are the policies to actually mean that, yes, actually there examples are made of this. Things are discussed properly. There is genuine learning. That is the next stage, isn't it, for us as an institution, the NHS, is to have that moral seriousness seeded in right from the beginning, such that, again, we should never ask the victim to be the one to have to fight this fight. But anyway, thank you so much to all of you for your
you for having
input.
us.
It's been brilliant, so thank you.